So the study was motivated by, as a young investigator, there's a real impasse in our field of heart rhythm disorders. So I look at atrial fibrillation, which is an irregular heart rhythm disorder, and we are not very successful at curing it with ablation. And the reason for that is because we don't understand why it occurs and why it persists. So the study was designed using a very selected group of patients in whom atrial fibrillation miraculously stopped with a single burn. And so I collected 25 of these patients to answer one question, which is, are we looking with the wrong tools? And is this why for 100 years we've been debating if the disease is complex or simple? Because we've basically been looking with the wrong tools, but at the same patients. So that's what the abstract is entitled, classical versus computational, because those are the methods that I use to answer this question. So that's the motivation for it, really. So I found that in these very unique 25 patients selected from over 200 who I screened with atrial fibrillation. So just to put this in context, these are patients who have had the disease for 6 to 7 years on average, who have got widely dilated heart structures in whom current success rates would be less than probably 40-30% with ablation. Each of these patients had the arrhythmia stop with 1 or 2 single burns. So these are kind of cases that would become case reports in journals in most hands, and I collected them and proved that actually looking at the electrograms or the signals that we record and analyze, if you use the signals to look at the atrial fibrillation in 2 methods, the classical and the computational, one method shows something you can target, which is this phase analysis, whereas the other method, which we've been using for the last 40-50 years, would have missed 80% of sources in those patients that would have otherwise led to a 20% termination rate. And so what I found is that phase analysis, or this new method of looking at atrial signals, is actually possibly one of the key reasons why there's been this century-old debate in our field. It's not actually the optical mapping we're using, but that's where phase analysis was derived from. So phase analysis was derived from optical mapping, which is the way you put this voltage-sensitive dye. And the first work to ever show a rotor, or this hurricane in the heart that we've identified, was in 1998 in a Nature paper using optical mapping. Our group and my mentors at Stanford and San Diego have developed a technique that applies exactly the same principles, but to the electrograms that clinicians record in the laboratory. So it's like an optical map in humans. We can't do that yet because the optical dyes are toxic to the heart. You have to paralyze the heart to stop it moving. And blood also, compared to water, is kind of opaque. So you can't really image optically. So this is the closest approximation to that we have clinically. And we see the same thing as with the optical maps, which is rotors, or organization in an otherwise disorganized rhythm. And that's what holds the key to treatment, targeting those sources of organization which drive the arrhythmia. We have a lot of data from this cohort, which I'm actually looking at exactly the question you just asked about optical mapping versus electrograms, whether that's another dichotomization as to why the results are so different between the 2 sets of data. We're also looking to see where these rotors live, because they seem to spin in certain places, and we wonder, because of a lot of other data coming out from other groups, that they might be anchored at scar points in the heart. So if you're old, if you're hypertensive, if you're diabetic, you will have microscopic scar that you're not aware of. But the MRI techniques of magnetic resonance imaging can pick up using very new dyes and new imaging methods. So we're trying to overlay those 2. So that's one of the projects I'm going on with my current next year's funding. And then there's other projects we're looking at as to why and how atrial fibrillation persists and why it takes sometimes longer to stop than others. So the ones I talked about, the 25, stop very quickly, like almost immediately. But there's patients in whom it burns on for a couple of minutes, burns on for a couple of hours, sometimes even overnight before it stops. And so we're looking at the mechanisms as to why AFib doesn't always stop, even if you take out a rotor. But mechanisms are fundamental, and that's what I'm kind of spending the next couple of years looking at Stanford and at Imperial College. They were first demonstrated in, as I mentioned in this Nature paper, which was in the ventricle. So VFib, or ventricular fibrillation, the biggest killer in the world, sudden cardiac death is the biggest problem we face as a community of anything, physicians or athletes or even the kind of public, is driven by ventricular fibrillation. That's been known for 3 decades now. In atrial fibrillation, it's been shown in animals up until 2012, and then our group showed it in humans for the first time. And what's more, we use them as targets for ablation. We're now using, or hoping, pilot studies to explore the same techniques of the baskets and the electrode kind of techniques that I presented in the ventricle to stop VFib. But that data is kind of just very kind of preliminary right now. But it's absolutely based in the ventricle, is well validated, and atrial, it's an area of much more controversy because nobody's seen them up until now. You must be aware of the methods that underlie the data that you're reading. So we are treating the same patients with AFib, but whether they're old, hypertension, blood pressure, age, obesity, whatever the cause is, they have mechanisms which, if we can identify, and if as a community we can come together and demonstrate areas that we can focus our treatments on, be it drugs or ablation or stem cells or whatever comes along in the future, we can improve treatment for AFib. And we're stuck at the moment at this 50% success rate, which is really unacceptable, and we need to kind of come together as a community to move forward because our patients are suffering.